I really don't know the calls. Like I must have thought you.
I'm not gonna go to the you know,
That's literally a fear of mine. Like
I know that. I the second that I do something wrong online, IRS is gonna come like, hey, you messed up.
I broken the audience.
So before we get started with this, always have something to say. I am for studying. I have definitely in my night class, probably not with you guys as much. My morning people seem to pay attention a little better, but I don't know what the deal is, but people have been complaining about they don't know what to study for both lecture or lab, which I feel like at this point, if you don't know what you're supposed to be studying, you clearly are not paying attention because I've said it like several times, but you need to be studying, but that's okay. I'll say it one more time in case you just happen to have a whole lot going on and you don't remember. For lecture, you need to be studying the study sheet. You need to understand what's on the study sheet. That's what you're supposed to be studying. If you're going through reading the textbook, wasting the time. Okay, don't do it. Seriously, like don't do that. Just go through what's on the actual study sheet. That's what we know. And like I said, you need to understand it. Yes, if you need to go into the textbook to read about it, that's fine. But don't like go trying to read all this extra stuff and learn all this extra stuff, right? So keep that in mind. Okay, the lab. I know I said it in lab, but just in case anybody's confused as I'm saying this, because you probably aren't even thinking how somebody could be confused about this. The lab worksheets that we have in lab, the front and the back. On the back, there's questions. On the front, there's like crap written on it, including like the, steps on how to do the experiment and all that, right? Above the steps, the part that like very few people read is some words that describe the stuff that you're supposed to learn for the class. That's what you need to be studying, okay? I'm pretty sure I said that in the lab like recently, but just in case I didn't, there it is. Yeah, so those worksheets, those are what you should be studying for the lab. And yeah, you need to know all of that, yes.
It's super hot. My phone is fully open at work.
That's fine, I don't mind. I would say go to lab, but it's probably really hot in there too, so it's not helping at all. I don't know, I haven't been in there, but I'm just assuming, right? So, but yeah, so that, if it's not clear, those worksheets, the information that is on those, you do actually have to know that stuff. I did say that at the beginning of the semester as well, when I was like showing you guys the sheets. I do understand that there was a lot going on where we were still just trying to figure out like what is even happening. So a lot of people just weren't listening or getting that. Just like a lot of people weren't listening or getting the fact that we have the unknown report that we do at the end of the semester, and everything that we've done in the first half of the semester, those results go on that report. And I said it at the beginning of the semester, but people don't really pay attention at the beginning of the semester. It's okay. We have a whole day dedicated to going over like what to expect from that report, what needs to be on it and everything like that. So it's not a big deal. We'll do that. If you, for whatever reason, don't have your results for your samples, I don't know. Most people still have their pictures that what they took for whatever it was that they uploaded, right? Most people still have that, so they usually know if it was positive or negative for whatever stain. Some of the stuff I can tell you just based on what your real result is, but I expect you to either remember it or, be able to figure it out somehow from your pictures or something else. In the past, if you didn't know your results from those stains for one of your samples and you weren't keeping track of it yourself, as you were made aware to do in the beginning of the semester, you were asked to do it again. That's what happened in the past. So I don't like to do that really because it wastes my time just as much as it wastes yours. So I don't really want to do it, but we'll do what we can to help you answer those questions if for whatever reason you don't have it. Of course, if you don't have it as an individual and somebody in your table does, come on, now that counts, okay? I don't need your proof of your answer. That's not what's important on that, okay? What I need is you to mark off the boxes on the checklist. And if you guys haven't looked at the report, it's literally just a checklist, okay? It's like you have your gram positive and your gram negative, and you either check whether it was positive or negative for whatever stain we did. And then there's some that you have to like describe what you saw as opposed to just positive or negative, okay? And just put like cells were red or something like that, but it's no big deal. It's not meant to be like this big crazy detail oriented, you provide evidence for everything. No, I was there with you. That's why you got credit for attending the lab. So, but you do need to know the answers just to fill out the sheet. Okay, that will make a lot more sense when we get into that one. But yes. I said this stuff at the beginning of the semester for a reason, right? But I'm reiterating it now also for a reason, because I just expected that people probably weren't listening in the beginning, okay? So you know now what you need to study for the lab. It's the stuff on the front, right? I sent you guys out the DNA sheet, yeah? If you haven't looked at it, if you do, you will realize that we've already learned this stuff in lecture. It's not new, okay? It's not new. It's just stuff from lecture that you do these things in labs like PCR, right? Like gel electrophoresis, that stuff. That's lab stuff that you have to know for the lab. That I'm not making you like do these experiments because they're actually incredibly finicky and they take a very long time to get to the answers. And I don't want to mess with it. Trust me, you don't want to mess with it. So you're just going to show me that you know that information that you have to know for the exam that was right before it anyways, right? So that's all that is. You don't have to know all of it, thankfully. Yeah, you don't have to know all of chapter 6 for the lab, but yeah, so that's what that is about. It's only 2 pages. I don't think it's even full. It might be full 2 pages, but it's again, all stuff that you would need to know for the lecture anyway, right? Some of the stuff I made little tidbits and comments on the information that you don't necessarily need to know for the lab. I'm not going to tell you which part you don't need to know. Sucks to suck, I guess. Because what's going to happen is you need to know that for the lecture. So some of that stuff is explaining stuff a little bit differently than how the lecture had it. So I want you to learn it. So that's why it's going to be that way, right? Hopefully that helps you guys understand some of it. I feel like rewording things, putting it in a different context. Even if you guys go watch some videos from somebody else about the stuff, you know, chapter 6 and chapter 8, that's the chapters to do that. Yeah, it's just a lot. Chapter 10 also, but I feel like it's a little bit more straightforward, but I don't know. So that's what you need to study. I hope that helps clarify some stuff for some people. Don't waste your time studying stuff that you don't need to know. You do have a lab manual. I'm aware that you have the lab manual. The lab manual is online for those of you that aren't aware of that. All of the stuff that you had to read, all those words and pictures and everything leading up to your pre-labs, that's your lab manual, y'all. That's your lab manual, okay? So I keep talking about the lab manual. Feels like I don't have a lab manual. If you answered the pre-lab questions, you'd have a lab manual, okay? And all that information in there that I make you sort through in order to answer those questions. And sometimes they're like a lot of them conceptual. Yeah, that's the stuff that, you know, in the past, I would have asked you to know everything in the lab manual. Luckily, you guys, all you need to know is the stuff on the front of those sheets, which is way less, okay? Way less than what's in the lab manual. Be aware of that. If you have any questions about it while you're studying, let me know. These study guides are pretty good for the midterm. They're not totally comprehensive. I am going to warn you about that, okay? Study guides for the lab midterm, they don't have really, I think, most of the DNA stuff on there, and you will be tested over DNA stuff, okay? But they do have questions on a lot of the topics. Not every single little thing. So don't rely solely on that, but do use it to help you understand the stuff, right? That's the idea. Okay. It is a little different from lecture, but if I give you a study sheet on top of that, I feel like I'm doing all of the work for you. So at that point, it seems a bit ridiculous. So that one, you have to do a little bit more work figuring out what's important or not. This one, I gave you a list of what's important. Okay. It's just a lot more information in here and a lot different, I feel like. Knowing, for example, in the lab, if I asked you about the Gram stain in one of the microscopes, you can come up to a microscope, look in the microscope, and it's got little round purple cells in little groups together, right? And the questions related to that could be things like, is this organism gram positive or gram negative? Purple, gram positive, right? What is the shape of the cells in this image? And there will be words that we have learned, things like bacilli, cocci, staphylo, strepto, those sorts of things. Usually about 4 or 5 choices. It's all multiple choice, and it's on Scantron, so I don't go beyond 5 typically. Okay, so it'll have those choices. But if I'm asking about the shape of the cell, you need to read the question. It says shape. Do not click on, do not fill in the bubble for staphylo, but that's not the shape of the cell. That's the arrangement. That is a different thing. And you will have probably questions about both of those. So you need to know the difference there, right? So cockeye would be the shape. Yeah, if I asked about arrangement, stack low, okay, cool. If I ask you about what the primary stain is for this procedure, if all you came up to was that microscope and it is purple, just like that bright, vivid purple, and I'm like, and the first question is, is this gram positive or gram negative? And then ask what's the primary stain for this procedure. Primary stain is always going to be the first one that you used. Okay. Primary stain for gram stain is crystal violet, right? You have to know those. Okay. So I will ask you, you'll have a list on there of all these stains that we used in lab. You better know which one goes with what stain. Okay. You better know why they work and why they use those stains as well, because other questions that you might see on the exam will ask stuff like, so what is the purpose of the crystal violet in the gram stain? And if you don't know that it's to, stick into the gram positive peptidoglycan cell wall, you got a problem, right? If I ask you a question on the exam, that is, what would happen? What would you see if you had a gram negative organism? Okay, first of all, you have to know what that would look like anyways. But imagine you had a gram negative organism and you forgot the alcohol step. What would it look like at the end? Right? It would be purple, by the way. You just wouldn't rinse the purple out ever. Okay? You have to know that as well. If I ask you about any step in any of the procedures that we did, I don't give a crap if it sat there for a minute or you did X amount of water washes, all this stuff that you guys are writing me in your lab summaries that I don't really care about. Y'all send me some journal entries basically, and it's fine. And I'm giving you credit because like so many people are doing it. I'm not going to fight it at this point, right? So it's just like, all right, you send me a journal entry, you like the lab and you did these things. Say, oh, today we did this stain and we saw purple cells and this table did blah, 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 and it was a lot of fun. That's what a lot of people's lab summaries sound like. If you guys knew, like people that write that, okay, if you guys who write stuff like that knew what some other people sent me, you would feel ashamed. I'm not kidding, because people are actually describing to me what the stain is for, and why it works and all of the stuff that we learned, the stuff that I meant for you guys to be putting in there. Like I said, if you're putting effort into it and you're sending me stuff and you're writing about the lab, you clearly were paying attention to the lab. So I want to give you the credit. It's just freaking extra credit. It's meant to be easy points, honestly. So I'm not getting picky. Don't need to change anything. Keep, doing what you're doing. But be aware of the fact that that's kind of what it was meant for, is to get you guys thinking about those concepts so that you actually were aware of them outside of me blabbing about them before lab, right? Because at that point, I feel like it was strange if I'm standing up there explaining, okay, so the crystal violet, and then this is alcohol is the decolorizer, and it's going to do this, and blah, blah, and I'm explaining everything of what the cells are going to look like at each step. And I don't know why people would think that I'm doing that. It's not for my own health. So that stuff you have to know, y'all. Not doing it for me. So yeah, so be aware of that. Those things are things that you had to know. Like I wasn't going over it because I thought it was fun, right? Or just to understand it for fun. No, you have to understand it to take the test, to pass the test. You absolutely will be tested over these things, okay? You'll be tested over which stains, what order they go in, because that's also important in the staining procedures, right? If you put your iodine first in your, gram stain, what are you doing? That's what is happening there, that sort of stuff. So that, what the acid fast is looking for, and all of that stuff. And then when we get into Kirby Bauer, when we get into ELISA, when we get into bacterial transformation and like the DNA stuff that you're expected to learn on your own, those aren't going to be, I will say this, for the DNA stuff, it's not going to be super complicated. I'll ask you about sizes. And there might be a question about like the steps in PCR. Like it's not going to be super crazy with the DNA stuff, okay? Just warning you. But the bacterial transformation will have a lot more questions about it because we actually are going to be like doing that in lab basically. So be aware of that one. I'm trying to think about like other stuff to talk about so that you guys can prepare a little bit better. Of course, we're going to have a review. The review absolutely will not cover everything. Okay, that's what going to the class was for. So,
Saturday.
it's in class. Yeah. So it'll be on whatever day before the exam, the day before, what class before, you know what I'm saying, right? So the exam for the lab is going to be on a Wednesday now. So the review will be on the Monday before. It is optional attendance, by the way. I usually do Zoom the review. So if you want to come in person, come in person, and you can come and ask questions and interact and whatever. And I can even show examples to you guys, that I can't necessarily show over Zoom, right? So I can physically like show you the thing. But, over Zoom, if you're watching over Zoom, that's great. You can still ask questions. If you want to watch the recording of it, that's on you. I am going to record it and post it though. Okay. It's an optional attendance day and I mean that. You will not be counted off, if you don't show up. It won't count against you as an absence if you don't show up. Okay. So yeah, so we will have a review. I basically go over stuff like I'm saying here with the Graham stuff. It gives you a sense of what you need to know about each of those topics. Okay. It's not gonna go into every detail though. Can't, it's just, that took me already, like whatever, however many lab periods, like 8 lab periods to go through. I can't just suddenly go through that. So anyways, do you guys have any questions about that before I get started with chapter 13? All right. I'll probably also make an announcement about what you guys need to study, because I'm sure there's still people that won't remember it when they get to actually studying. Okay, let's go. So chapter 13 is dealing basically with disease and the mechanics of disease and what's going on with disease. So we're finally getting into really doing the stuff that you guys are here for. Yeah, so we're getting into what's important about diseases. We already know disease has to deal with a deviation from the norm. That's really all it is. Anytime you have a deviation in a negative way from what you normally have going on, that's disease, right? You can have disease that is infectious, which is what we're focusing on in the class, or you can have disease that's not, like cancer or, heart disease, things like that. In our bodies, another thing that is important as far as understanding basically how everything's going to end up working together, especially whenever we start talking about the diseases in Unit 4, the biomes of these areas of your body, okay? You have bacteria, pretty much, not even just bacteria, fungi, protozoa, and viruses, pretty much anywhere on your body, except for places like you shouldn't have it in your bloodstream. Shouldn't have anything in there besides your stuff, okay? But there will be if there are infections involved. You really shouldn't have it in any of your central nervous system. It's a really bad thing if you have that, okay? So stuff like that. But a lot of it has some sort of organism associated with it that'll grow on there. Things like Staphylococcus epidermidis. And that should be obvious. So like E. coli, regular E. coli in your gut, that's normal stuff. Yeah. What we can say here, basically, we have the bacteria, the fungi, the protozoa, and the viruses. That's 4 things. And remember about that 4 things, there's something that's missing in this list of the things that we've learned about, right? The thing that is missing, helminths. Helminths are not up here, okay? Helminths are not part of your biome, despite what people online want to tell you about all the worms in your colon that you need to get rid of by taking HeartGuard for yourself or whatever it is. You don't have worms in your gut. You don't. And people be like, well, they take it. And then, whenever they use the restroom, it looks like worms there. I'm like, I bet it does, because they're sloughing off the lining of their intestine, because you're not supposed to be taking ivermectin. It's not good for you, right? So don't do it. Yes, whenever you slough off the lining of your intestine due to chemicals or inflammation, even people with ulcerative colitis will know what I'm talking about. You slough off that lining, it looks like worms. The way that it comes out, like they'll be like worms, round, long, whatever. But it's literally the tissue on the inside of your intestine. So yeah, I bet it does look like worms. Here's the thing: how many people are having colonoscopies every day? How many of those doctors are seeing worms up in there? They give you pictures of it. It's not like they're lying to you or something. I don't know what people are thinking sometimes. You don't have worms unless you've been to a third world country and you were like drinking the water and bathing in it and stuff. You're probably fine. So yeah, so no helminths. That's not normal. Worms, not normal. Okay, the whole thing, again, we talked about holoenzymes. The whole enzyme, right? That's going to be the combination between the actual protein part, the apoenzyme, and the cofactor, whatever it is, right? So we have holobiont as well. That's going to be you plus your biome. That's all it is. The whole of you. We know that having a normal, healthy biome is important as far as preventing overgrowth from harmful organisms. If you are having all your helpful bacteria in your gut, let's say, taking up all of my best example is the stadium seeds, okay? If you have these guys taking up all of the stadium seeds, the bad guys can't sit down, right? That would be an example of preventing overgrowth of harmful microorganisms. They just don't have the room or availability of nutrients to do it. We also have influencing development of organs, especially the immune system. So it's training your body as to what is friendly and what isn't friendly and what to react to and what not to react to as far as the immune system goes. And then how your body sees what's going on with your normal biome can affect how your organs adapt as you grow. Anyways, microbial antagonism, this is the term that I would be familiar with if I were you. Microbial antagonism, I know for a fact I have this on a test. I just wrote this question. There's a question that at least refers to this, I'm just saying. So it'd be helpful to know what it is, but so you know your choices. But it's one of the choices of something, FYI, in case you haven't figured that out. So basically what we're talking about here is whenever your good microbes are protecting you from the bad ones, either from taking up the stadium seeds or by producing toxins that'll get rid of those guys or whatever it is, somehow they are protecting us from bad guys. That's microbial antagonism, okay? An antagonist, just like you have in a book. In order to have an antagonist, you need to have, you know, conflict there. So microbial, they're fighting each other. And where do we get our biome? You start your biome, they're saying now, in the womb. Okay, you start out in the womb where your mother used to think that the womb was actually sterile, but it's now been found that it is not, and that the bacteria and other biome organisms in the womb can actually start colonizing the fetus, the baby, while it's developing. And then, of course, while you're being born, you're exposed to the flora of the vagina or the flora of, if you're going through a C-section, whatever's on the skin of the mother. And potentially people who are interacting with the baby right after birth, right? And then breast milk, which we are probably all aware of, colostrum and everything that is inside of there. It's not just antibodies and that stuff that's good for you. There are really good healthy bacteria that are in breast milk, as well as especially the colostrum, that can help break down sugars that your body can't do on its own. And so that helps colonize your gut with bacteria that can break down sugars. Anyways, that's the idea. So we know in utero, you start getting stuff in utero. The womb has its own microbiota. Then you get born, C-section or vaginal. You can imagine, probably don't need to say it, that the bacteria that you're getting exposed to by a vaginal birth versus C-section are going to be completely different. So that can affect the health of that individual as they are growing. No joke. Milk. We have breast milk has its own biome, especially the colostrum, but breast milk continues to have its own biome for as long as you are drinking it. And you're getting those healthy bacteria that are going to colonize your own gut and break down sugars you couldn't otherwise do. So if you are not breastfeeding and your child is not receiving breast milk, you should make sure that you are feeding them formula that has probiotics in it, basically, bacteria that are good. Yes.
Kind of a weird fact. Is that breast milk gets rid of pink eye?
Wait, what? It gets rid of pink eye? That kind of makes sense, yeah.
So, well, I was homeschooled, so let me just preface this. And some friends in high school, their mom just had a baby, and they all had pink eye because they all played football, and just their breast milk in their eyes, and they got rid of it real fast.
Wow.
There's that, man.
Yeah, that is a fact. Yeah, it's not too surprising considering what's in breast milk. It's not just milk. We know that it's the biome as well as antibodies and stuff like that from the mother. It's good. It is. And then we have caregivers. Caregivers, people who are handling the child afterwards, and then the environment. Of course, you're a baby playing with the family dog, or you're crawling on the carpet, or whatever it is, you're getting exposed to different microbes. And those can become incorporated as part of your biome. So if we're talking about the baby getting exposed to all this stuff when it's first being born, you'll get colonized at this point. But clearly, as you grow up, as you age, as you get exposed to new things and interact with new things, your biome's going to change. It never stops changing. Imagine you're going through puberty, and now you've got this whole set of new, especially for females, a whole set of new bacteria that are associated with having hormones, of changing the whole environment in the vagina, in that whole region. There's that, or you can think about, you know, maybe the first time that you have sex with somebody. That's someone's whole other flora that you're exposing yourself to. Some of their flora might become part of your flora, and vice versa, you know. So it's not ever going to stop changing. It's not permanent. That's my point is. All right, colonization, infection, and disease. We already know about kind of the 5 I's as far as investigating the bacteria. Some of those steps still apply as far as when we're colonizing somebody. We still need to inoculate the person, so expose them to the bacteria, and that needs to incubate within the person and whatever else, right? But it's just happening all within the person. No investigating, obviously, but those first steps apply. So an infection is a condition where pathogenic organisms will penetrate host defenses, enter the tissues, and multiply. They have to at least have the propensity to be pathogenic, okay? It might not be at first. Then disease is that deviation from health, right? Due to, we would say, you would notice it as damage and disruption of tissues and organs. You'd have symptoms, signs and symptoms as a result. But yeah. All right. What other things affect infection and your susceptibility to it and your ability to fight it off and everything? Age, genetic defects, acquired genetic defects like AIDS, pregnancy, organ transplants. If you've had an organ transplant, you're on immunosuppressants. You are, like, you have to be. So that's a problem if you're exposed to things. Surgery, of course, your body is damaged and it's trying to focus on healing. It's gonna be a little bit more susceptible to infection because it's focusing on something else. Same reason for pregnancy. That's really what's going on. Your body's focusing on making a person. So your immune system typically is lower. If you're taking any immunosuppressive drugs for any reason, or chemotherapy, that affects your immune system as well. And physical, mental stress, and underlying diseases you may or may not know about. So this can all, you know, basically stifle the normal system. Yes, what's up?
Do diseases start out as infections, and then once it grows into the organs, then it's classified as a disease?
Yes, once it starts having like the actual damage, that would be disease at that point. Yes. So you start out as an infection. You can have infection too that maybe doesn't cause disease. Maybe you don't have any signs of the infection whatsoever. You can carry the disease, right? I don't know if you guys know this, you probably do, but 1/3 of the people who will be infected with COVID will never have any symptoms at all. So I'm talking about there might be people sitting in here right now that think they're healthy, that actually have COVID. But is that considered a disease? No, because they're not having any symptoms. I mean, we just said if there's not any damage being done, how would you know? Is it an infection? Technically, yes, because it's a pathogenic organism that you're being colonized with. It's just not causing damage to you. So 1/3 of people, that's quite a lot.
Same thing with tuberculosis too. You can be a carrier.
Yep, exactly. Especially when it's latent, like a lot of people don't even know. All right, so endogenous infections, these are infections that come from bacteria that are already in your own body. Okay, they're just normally hanging out and chill, but something happens, something shifts that causes them to overgrow in the area they're already in, or to grow in areas they shouldn't be in. Okay, so example, it says Streptococcus pneumoniae, usually normal biota. It's a very, very common bacteria. And this sucker causes so many diseases, it is ridiculous. You probably think, okay, yeah, Streptococcus pneumoniae. Okay, so it's gonna cause pneumonia. Well, yeah, of course it is. This is a pneumococcal pneumonia seen mostly in AIDS patients. That's nice. It's also the most common cause of meningitis, FYI. And meningitis, bacterial meningitis of any form is no joke. I mean, I want to say the worst one, which is Neisseria meningitis, it's a lot more deadly, but I feel like this is still like 30% if you get a full infection of dying, is what I'm saying. So it's no joke. If you guys, I'm sure you've heard about it, you know, they say that get the pneumococcus vaccine. That's what they're talking about. It's this. It also causes pneumonia, clearly. It's in the name of it. But we'll get to that. Well, that guy's going to appear a lot in our disease area. So that came from a normal place. I'll also give you another example that's a little bit more obvious that we can actually, most of us, at least the women in here probably can relate to, a UTI, urinary tract infections. 80% of urinary tract infections are contracted from E. coli from your own body. Okay, yeah, from your butt is what I'm talking about, but it's just a lot of times due to sex, we've got a whole lot of, mingling going on up in there, as well as a shift in your biome typically from whatever's going on, and then makes you more susceptible to getting your own bacteria into that area where it doesn't belong. It doesn't belong there. It's not normal. Okay, so humans can become colonized. They can go through all these different ways of getting infected. So the whole biome, the normal person plus their biome, potential pathogens and things that are just there. Like if you, a transient pathogen, what it's talking about is like if I were to handle this and then you guys come up and grab it and you got, my germs from touching that, that's transient, right? That was just probably you're not going to get sick from it or anything. You're probably going to wash your hands and be fine, or not even know, like not even think about it. That's the more common thing, right? How many people do you think have sat at these tables that you guys are touching? So that sort of stuff. Honestly, probably not very many people because everybody hates this lecture room. I'm just saying. Everybody does. It's usually just me and Dr. Tim that use this room, and he has refused to use it. So, there's crying babies next door. Not today, but yeah, there can be. That's the CFSI. So yeah, next door. CFSI is for like people with families that are taking college and they're getting like help and support. It's a support system for people with kids. Yeah, if you guys haven't heard of it, you should look into it. I don't know if it's a good program, but there's a lot of babies that come over there.
It's a
So.
good program, but you have to go here like all day, almost every day.
Oh yeah.
They do class from 9 to 10.
Oh yeah.
The two people that run it are also in the PCK. And they're really good people. Same one.
I would say like dedication, because one of them, I don't know who it is, like I'll come up here on the weekends to do some work. Always here. Always. I mean, every time I come up here, their car is here, they're in their office working on the weekend, Saturday and Sunday. So that's dedication. So those are people that care. That means they care. Anyways, yeah, you can get bacteria on you. Maybe they're pathogens that are going to just come and go and they're gone and you don't have any problem with it. Maybe pathogens that potential pathogens and occasionally resident biota will lead to infection. Yeah, sometimes the pathogens will cause infection. Maybe after, colonizing you, we don't have any symptoms and we'll clear it anyways. You would never know it was there, but still it does count as an infection. Anyways, sometimes it gets an infection and causes disease. That's going to be dealing with signs and symptoms now, causing damage to the body. You could die from that. Sometimes you can become part of the holobiont, and then most of the time you're going to be eliminating them. That's the problem. So that's the idea of how biome, microbes, everything can interact with one another. I don't need you to know right now any of this, as far as it's just going over things that are involved in it. Even points out bacteria, fungi, protozoa, and stuff like that. Viruses can be part of it too, but they're usually not that interesting, so they usually don't talk about them that much. But yeah, you don't need to know those details. We'll come back to those in the disease chapters. I'll let you know if I need you to know it. All right, a pathogen is a relationship where we have a parasitic disease, so causing damage to the host, causing disease, right? True pathogens, they're going to cause disease even in healthy people. So that's an important one. True pathogen, cause disease in healthy people. A pathogen is something that can cause disease in general, is capable of it at least. We also have opportunistic pathogens. These guys can cause disease in certain circumstances. Usually the defenses are compromised, or immune system is compromised somehow, or they get introduced to a part of the body that they don't belong in, like that E. coli I was talking about. So it's opportunistic. It's just taking advantage of the opportunity to colonize your urinary tract. All right, so based on basically the pathogenicity, the ability to control the spread of these organisms, as well as how dangerous the symptoms and everything can be, okay, we have organized things into biosafety levels. So there, of course, are going to be some things that aren't going to even really cause disease. For example, Staphylococcus epidermidis. Not associated with disease. So we can handle that even at a BSL 0 setting. So the BSL 0 is like this room, okay? And then we have BSL 1, that's going to be in a laboratory, but it's open bench, like what we do in our lab. Okay, so that's all BSL 1 work. At BSL 2, we have one Plus, we have to be trained in handling the pathogens. You will be wearing coats and gloves. You will be wearing gloves. We don't wear gloves in our lab because we are BSL-1. If we were BSL-2, you would be wearing gloves, be required. And we would have safety cabinets, biohazard signs, access would be restricted, all this stuff, because we don't want people getting in and out with what essentially is going to be pathogens. So what am I talking about in this case? We're talking about pathogenic versions of Staph aureus and E. coli and Salmonella. And yes, we're working with these organisms. They are not the pathogenic versions. Okay, they're not. So just be aware of that. So if they were pathogenic versions of those, bam, BSL-2 instantly. Okay. All right, BSL-3, of course, we're going to be doing the same thing. You got your coats and gloves and everything's labeled biohazard and you have access being restricted. Great. And then we're going to have special containment. So that could be, you have to have negative pressure. So that means less pressure inside, greater pressure outside. So if there's some sort of risk of contamination to the outside environment, the air rushes in as opposed to out. Okay, we have that going on. So we have essentially the airflow completely controlled in that sort of a setting. Special clothing, like you can wear, you guys even know about this, like PPE, that's like throwaway kind of stuff. They usually work with that stuff, little booties and all that stuff. You might even go through changing areas and all this stuff to get in there. And sometimes they even wear these little hoods that like blow air out so that things couldn't get up into the hoods. If you work for the Army, they're going to stretch their little rules a little bit, and they have what they call BSL-3 plus. And so it's in a super contained area, and you wear just the hoods, and you have the disposable clothes and everything. So it's like the extreme end of BSL-3, but they really push the limits with it, so that they can work with stuff that isn't at BSL-4, basically. But otherwise, everybody else works with it at BSL-4. So BSL-3 includes things like the plague, like tuberculosis, brucella, and all these other things. These things, tularemia and brucella, these are considered a risk for bioterrorism. And we have yellow fever and HIV due to the danger associated with these infections, right? So that's BSL-3. BSL-4 is going to be 3 stuff, plus you're going to be extremely controlled access. So the CDC used to use, I don't know if they still do, they used to use retinal scans, like literally actually retinal scans to get into their facility. Just this part of it, okay? Not everybody at the CDC can get into it. You had to have special access. And they have like showers that you'll go through, going in and coming out. Of course, coming out is the more important thing. You might physically shower your body, as well as whatever suit you are wearing in there gets showered with chemicals as well. So when they were building their, I don't know if it's still new to them, this was back in 2008, I think, but I went to go visit their new facility, and they're giving us a tour of it before they opened it up. And they're doing all their testing, and they had 4 suites, 4 hot suites, so 4 BSL-4 suites. And they're doing testing in one of them, so they're complete sanitizing of each one. They can literally shut down a whole suite and just sanitize it with like toxic fumes and shit. So like everything in there dies. So they can just like keep it clean. That's how they clean it, basically. They cycle it between. Anyways, I thought that was really cool, but then you go in, you have to go through and change all these clothes. They have their BSL-3s on the outside of their floors. So you're already like kind of set up to go in there. BSL-4, they have these suits, those like rubber looking suits that you guys used to see on like Outbreak and stuff. That's real, that they actually wear it. And the little hat hoods that they put on with that, and then hook up the little air hose to themselves. So if you're working there, you'd have that on, and you're usually just standing in a chemical shower first, and it's hot chemical on you for like an entire minute, I think is how it has to go, before you go in and whenever you're coming out. You don't hook up to air at that point. So you have to be sure that like, you know, you're not in a bad situation at that point. So you wait, you're just standing there. Only one person really can fit in there. So if you were trying to panic to get through it, if something was going wrong, everybody would have to wait their turn. So that was kind of terrifying. And there's like windows, so you can see into like the next area. Can you imagine if like somebody's having this catastrophe and you're just like standing there in your chemical shower and you're like, I'm out, like I'm not doing it. I can't imagine what that would be like. But yeah, so they have that, and then they get in there and they hook their little air up right away. So you go in there, you don't have your air up right away. You have to do that right away. And that starts the air flowing and pushing air out of your suit. The whole area, the whole entire suite is going to be negative pressure so that if something goes wrong there, air rushes into that. Out of you, into the room. So keeping everything contained. And of course they have biosafety hoods and everything. And their gloves that they wear whenever they're doing this, they are like those thick rubbery kind of gloves. How are you handling like all these like micro pipetters and everything with these gloves? I don't know. I used to think I wanted to do that until I started like talking to the guys that do it and like going to the facilities and everything. And I was like, maybe I would have a fan with that. Because I think I would probably. Because you're looking through plastic the whole time. You hear yourself breathing the whole time. It's like, I don't know, knowing there's Ebola right there, like it's just, how do you do it?
They caught it very quickly.
Yeah.
When I was deployed, we had a full guard on one of the Djiboutian senators. And we had to wear it with our full body armor and all of it on the outside. You could barely fit your finger in the trigger belt.
Yeah, I bet. That's I can't imagine working with that. I mean, see, that would make me panicky just to, I couldn't block that out of my mind. I wouldn't be able to. So I'm not built for that. That's what I went to school for, was to deal with that stuff. That's why I started working with the CDC and with the Army. I worked very, very closely with them. But I just had them do all of that work for me. Okay, so that's what I did, and I just did the molecular side of things. So this includes, of course, Ebola and other filoviruses like Marburg. There's Lassa fever, which is a similar hemorrhagic fever. A lot of the hemorrhagic fevers are going to fall here. The one I was working with was Crimean Congo hemorrhagic fever. There aren't very many BSL-4 labs in the United States. CDC's lab, with their 4 little suites that they rotate their use of, they have deep freezes in each of them, and they rotate certain boxes randomly. Okay, and there is some sort of bank somewhere that knows the answer of what is in what and where and how. But the reason they do that is that because one of those boxes has live smallpox in it. So that is where our stores of smallpox are kept publicly anyways. Huh?
Sounds safe.
Yeah, right. Exactly. So that's where those are kept publicly. I'm sure that the Army has their own stuff that they're working with. So you know how that goes. Anyways, so virulence deals with the pathogenicity, its ability to cause disease. A virulence factor is anything that is associated with causing disease, anything. So it could be flagella or it could be toxin production. We have infectious dose. This is something that is dealing with how many microbes typically you have to get into your body in order to lead to a productive infection for that organism, okay? So microbes with smaller infectious doses have greater virulence. For example, if you only need 1 virus to get into somebody in order to establish an infection versus like 10 bacteria to get into somebody, that's different. That's completely different. You need to have the 10 bacteria there. 10 is the ID for tuberculosis, and a lot of viruses, a lot of them have ID of 1. So polymicrobial, this is not a surprise. Polymicrobial, more than 1 microbe is associated whenever you have an infection. So who is surprised if I tell you that people who have the flu often have pneumonia caused by bacteria? Right, that's not surprising. So that's all that's talking about. Right, causing disease. First, you have to get in. That's the portal of entry. Second, we have attaching, so finding your spot that you're going to stick to. Then you have to survive whatever the defenses are of the host. At that point, you can cause damage, okay? Because you've established yourself there and you can start multiplying and creating toxins or whatever. And then once things are good, or at least like the ones that you've multiplied out are ready to go, they'll exit the host. That's the idea of what we're going to go through. So portals of entry can be exogenous or endogenous. Like we said, if it's already existing in the body, like the E. coli was for the UTI. Exogenous is going to be from outside. So like COVID. You can get in through the skin, through nicks and punctures and abrasions. Some of them can penetrate intact skin. So some pathogens like the helminths can do that. Obviously, if you're going through the mouth, that way you have to be resistant to the acid in the GI tract or bile, all of that stuff. Respiratory tract, yeah, obviously oral cavity and nasal cavity, and then whatever's going on in the lungs, you have to be able to survive that if you're respiratory. And then urogenital, we've got sexually transmitted infections that are associated with sexual contact, but you can have other infections there that are not sexually transmitted, of course. So entry points through any of the, I feel like reproductive area organs, okay? Any of them. We'll get into those to the last chapter of everything. So, let's see. Birth, we already talked about this. Placenta being the exchange organ for, blood, gases, everything like that. Well, that can lead to exchange of microbes as well, sometimes. Usually maintained, we can usually prevent it, but there are ways that it can cross. Some of them just able to, so it gets transmitted. So the ones that are usually associated with being transmitted from the mother to the fetus, we remember them by torch, which is like the vaguest thing, because let me tell you guys. The first one's toxoplasmosis. Fine. That's a protozoa, right? That's the one that's in the cat poop, don't handle the litter, everything. Right? Can be bad for the baby more than it is for the mother. Then we have next O is other diseases. Now, come on. I just can't with that. That's why I don't like this one very much, because I just feel like this, who cares? Like at this point, just say all the diseases. But anyways, usually it's associated with syphilis, Coxsackie virus. Coxsackie virus is going to be the foot and mouth, hand-foot mouth disease. Whatever. You guys know what I'm talking about, this rashes and everything on the kids. And then we have varicella zoster virus, that is chickenpox, AIDS, and then chlamydia. Then we have rubella. You guys probably have heard of rubella solely because of the vaccine. Measles, mumps, rubella, MMR, right? The reason you don't hear about it otherwise is it doesn't really affect adults or children. It affects babies in the womb, fetus, okay? It is deadly, extremely deadly to them. So if you're a mother and you get rubella, you weren't vaccinated, and now you've got the rubella and it's getting passed to your baby, you probably are going to lose that baby. So it's really terrible. It's a really bad one. Then we have, but if you're vaccinated, nobody is going to talk to you about it. So who cares? Of course, you guys hear, maybe you didn't, I got an email or something about it from, of course, the Weather Channel, because that makes sense. For the Weather Channel decided to tell me there's an outbreak of measles at a school in Florida. That's a problem, right? People like that who aren't getting their MMR vaccines, you're going to be anti-vax, you're not going to get vaccinated. I am going to judge you, just by the way. But I absolutely just completely disagree with people who do that. I do think that it has to do with public safety of others, not just yourself, right? So they're choosing not to get vaccinated or to vaccinate their children, and they're getting sick from all of this. What if one of those mothers gets pregnant and gets rubella? They don't think about that. They think of the measles, because that's where all this started with like the autism and the vaccine and all of this. Yeah, that's all they think of. Yeah, we'll get to that a little bit later, but remember that autism report that was issued, that Jenny McCarthy was the one that started all of this. She's the one that found that and started talking to that doctor. He falsified all of his evidence. Like literally, he redacted everything that he published. It was made to, because it was all a lie. It actually was a lie. So there's no evidence at all that at least the MMR vaccine in his studies causes autism. There's absolutely no evidence. That's fake. I don't know, man. I'd rather not know it. I don't know. You probably easily Google it. I'm not sure what his name is. But yeah. So then cytomegalovirus. This one's dangerous, again, for the fetus, but not for the person. It causes mild cold in people. They'll test you for this if you donate blood, CMV. Last time I donated blood, I was still CMV negative. I just feel like any moment now it's coming. All right, herpes simplex. That shouldn't be too surprising that you can, if you're having an outbreak of herpes, that you can pass that on to your kid, especially whenever you are giving birth. In fact, it can be so serious that if you are giving birth and your child does contract herpes simplex virus and it is able to get into the nervous system of the child, which isn't uncommon, okay, usually through the eyes or exposure through the eyes or something like that, it's like 80% fatal. So if you have ever heard or ever worked in a ward where there's babies being born, if you have herpes and you are having any sign of having an outbreak of that herpes, they will give you a C-section. I mean, you don't get an option. So, because people think they know better until they learn this stuff. So yeah, can die, can have all sorts of stuff happen to the baby as a result of those. We'll get kind of into some of those later on. All right, do you attach to the host? We've already kind of learned about attachment. The main structures for attachment, maybe fimbriae for attachment, remember? Flagella for moving around. So that you can attach whatever. We have our little sticky coating from our capsule and our slime layer. That's going to be quorum, how we create a biofilm. We communicate within the biofilm via quorum sensing, which we learned, I think, chapter 9. Yeah. So this is just kind of reprising that stuff. But here's the idea. We've got bacteria up top that have fimbriae that are using those to attach to the host cell. Here on B, we have capsules. So that sticky coating allows us to attach to that host cell. And then some viruses that are going to attach to that host cell using that spike to the receptor, that lock and key mechanism of that glycoprotein. Remember that from chapter 7. So here's some examples of how some of these guys adhere whenever they finally are able to. We're not going to memorize them, but that's there if you're interested. Next, we have to survive the host defense. Number 1, the first thing you're going to see absolutely, no matter what, is going to be the phagocytes. They're freaking everywhere. There's a reason they're everywhere because they're constantly surveilling for bad guys or, dead tissue or whatever it is that they need to gobble up and get rid of. These guys engulf, they destroy pathogens, they have the enzymes, they have antimicrobial chemicals. Remember, they have those oxygen singlets or whatever that they can put in there, and lysozyme. Lysozyme is an enzyme that will break down peptidoglycans specifically. So we'll include that in there. Anything that helps an organism defend against that is called an antiphagocytic factor. Okay. Some of these guys, it's because they will kill the phagocyte. Some of these guys, it's because they actually live in the phagocyte. And they'll just settle in and make home there. They might have defensive chemicals, or they might just inhibit something about that phagocyte doing its function. Tuberculosis is one of those. It lives inside of our cells. Inside of the alveolar macrophages in your lungs. Specifically designed to kill these guys. They like it. Yeah, send more is what they say. Okay, we have epigenetic mechanisms. This is basically, they have an effect on our genes, if you will, and how we respond to things. Not like on a huge, massive level, but they can affect certain aspects sometimes. Or who cares? I'm not going to test you on that one. Then leading on, so we've adhered and we've started, establishing our infection. We're, evading the host response. Now we're going to cause disease. We're going to use our virulence factors here. Anything that helps us cause disease is going to be a virulence factor. Structures, products, capabilities, right? We know a lot of the enzymes that are toxins, but also it could be having a flagella, stuff like that. So here we have a list of secreting proteins like enzymes or toxins, like I just mentioned, breaking in between the cells or breaking down aspects of the cells themselves, causing an overreaction of the body's defenses. And that can lead to host damage. They might not always be meaning to do it, but that can be something that they do that causes damage to your body. So whatever. And then altering our genome or transcription process. That's usually the epigenetic crap that we just talked about. Okay. They can do that stuff. That is still also considered part of the virulence factors. Okay, so causing damage with the enzymes. Those exoenzymes that are secreted by these guys, we mentioned that collagenase, or you can even talk about the penicillinase. Here's some other ones. Mucinase to break down mucus, keratinase to break down keratin in your cells on your skin, and then hyaluronidase. Hyaluronic acid is also part of your extracellular matrix and what helps maintain your tissues. Okay, so that's all ways that they can get inside better. We keep talking about toxins. That's anything made by organisms that is poison to another organism. Poison meaning it causes some damage or death. Exotoxins are secreted by the living thing. And then endotoxins, they're not actively secreted, but are part of the organism, but they're still toxic to us. Now you guys remember, this shouldn't be a surprise. This is a word that we've seen before. I used to say a lot, endotoxin. You guys remember about that one? Or I used to say endotoxin. It's the same thing as lipopolysaccharide, LPS. That's found on the outside membrane of gram negatives. Gram positives don't have that. Only gram negatives have it on their outside. It's LPS. It's just one of those markers they have. And it is called also endotoxin. And our body reacts to it like it's a toxin. It's endo, part of those gram negatives, though. They're not secreting it. It's not exo. So our body immediately sees it and reacts to it in all these different ways. So this is just a chart comparing what the exotoxins can do versus the endotoxin. And I don't need you to memorize the differences, but if you are interested, it is there. We remember hemolysis and breaking down red blood cells. This is the freaking same slide as we saw before. But those are enzymes that allow them to do that. And of course, that would be bad for us to have that, right? That hemolysis would be bad inside of your body. That's an example as well. The excessive host response, so overreacting. So like the pathogenicity, like I keep saying about how some organisms are going to be more pathogenic than others. They're going to cause more disease and symptoms and things like that than others. One way that they do that is if they induce that host response, you know, have all this inflammatory response and you're getting all this inflammatory response going and it's making you feel bad and it's causing damage to your own tissues as a result. That's what they mean by the excessive host response. However, that pathogenicity then is being determined by you reacting to it, not necessarily by the organism. It's not making that response. You're just reacting to it. So that's what this is talking about, being consequence of interplay between microbe and host. It's not just one or the other. So scientists speculate that symptoms of long COVID are caused by overstimulated immune response. So people who potentially have experienced symptoms of long COVID, perhaps they overreacted to COVID. Okay. So you can have localized infections in one spot. You can have systemic infections all over the body. You can have focal infections, which kind of stay to a couple locations transmitted between one another. We have that are related to one another typically. Then we have mixed infections where you have more than one microbe involved. And then we have secondary infections and primary infections. So just comparing them that way. So the initial infection, you treat this one, take an antibiotic against it, and now this guy's going to grow up because that guy was gone. That's like an example of what could happen. We know that this is a thing in the urinary tract infections, right? Sorry, you go have a urinary tract infection, y'all, and they give you an antibiotic for it, you're at a risk. And sometimes they'll warn you too, if your doctor's any good. You're at a risk. Watch out for symptoms of yeast infection, right? You're killing all your bacteria. The normal yeast in your body, which is normal to have, can now overgrow. So you could just be in like this cycle between bacteria. It can be pretty annoying. There is a possibility for that. So those are dealing with primary and secondary. Anyways, we did it. I'm just giving examples. I don't know. I don't really need to know too much about them. Yeah, freaking low. So, polymicrobial, primary, secondary, yes. Okay, then we have acute versus chronic infections. Okay, we know acute is going to be something we usually think of short term, right? It's going to be usually strong effects, short term, short-lived. Chronic infections tend to have lower level of symptoms, but over longer periods of time. All right, these terms here, you absolutely need to be able to recognize the differences between these terms and know which one's which, okay? Signs. These are objective evidence. We can note them and write down as observers what they were. So we say more precise than symptoms. I'm going to be more clear about this, okay? Signs, anything you can measure. If you can measure or observe it directly yourself as a nurse or healthcare practitioner, that's a sign, okay? Even swollen lymph nodes, you can palpate that and see. Taking somebody's temperature, right? Running CBC and seeing they have elevated white cells, leukopenia, that sort of stuff. Those are all examples of signs. There, you can see it, right? So the next one, so what's an example of a symptom? Y'all probably been using these words wrong your whole life. All right, so symptoms, those are subjective. So your patient has a headache. That's probably the most common one is pain. Because how do you measure that, right? You can make them look at the chart on the board and say that I'm, you know, this sad face here, but anybody could say that, right? So how do you know if they're in pain? How do you know if they're fatigued and that sort of stuff? Nausea, vomiting you can see. Nausea you might not, you know, abdominal discomfort, all these things. you can't see them. You have to just go by what the patient is telling you, right? So signs, I think of a sign like that's a physical thing that you could actually have and see and touch. A sign, like a stop sign, right? You could see and touch that, just like you could signs in medicine. You can measure literally. Then the symptoms, a little bit more vague, okay? Subjective. The next word on here is syndrome. This is one that people, I don't know why it's on the same slide, but it is, so we're just going to talk about it here. Most people don't know what this is either. Most people think of syndrome as just this term that nobody ever actually uses or is ever like associated with a thing. But let me tell you, it is. Let me give you an example. My favorite example, I feel like it's the most obvious one, which would be meningitis. I already mentioned it once, let's go with it now. I already told you about meningitis that's caused by Streptococcus pneumoniae, right? That's the most common. So that I told you that's the most common. What does that say to you? There's other ones that can cause meningitis, right? Neisseria meningitis and Listeria monocytogenes, Haemophilus influenzae. These are all bacterial causes. Hib, if you've ever heard of the Hib vaccine, that's Haemophilus influenzae, type B. So this is just bacterial versions. You can have fungal meningitis, and you can also have obviously viral meningitis, right? Herpes, actually, that's what we are talking about when we say that it is harmful to the babies and gets to their brain and everything. Causes meningitis. Meningitis is just the inflammation of the lining of your central nervous system, your brain specifically, right? The dry matter and all that stuff. So it's all inflamed and all that. But all of them have the same symptoms, right? We're talking about headache, stiff neck, fatigue, probably have a fever, sensitivity to light. They all have the same exact symptoms. We call them all meningitis. Therefore, meningitis is a syndrome. Okay. So because they're all associated with those symptoms with different organisms. Another one, cold. Obviously, the common cold is caused by so many different viruses. Oh my gosh. Whether it's CMV, like we just mentioned, adenovirus, rhinovirus, RSV, those all can cause cold. Another syndrome. Okay? Pneumonia is a pretty good one too. We could go through that, but I'm not going to. But you guys know what I'm talking about. If I talk about the plague, that's caused by one thing, right? That's not a syndrome. That's caused by one thing. All right, let's move on. Here are some examples of signs, just in case you were paying attention. Fever, septicemia, we can measure that. Microbes in any tissue fluids. Chest sounds, you can hear those. Skin eruptions, leukocytosis and leukopenia. Swollen lymph nodes, abscesses, tachycardia, and antibodies that are present in the serum against a specific organism. Okay. Symptoms, chills, pain, soreness, malaise, feeling like crap, basically. Chest tightness, itching, headache, nausea, abdominal cramps, anorexia, and sore throat. Anorexia just means you don't want to eat. Right, leukocytosis, you have an increase in the white blood cells. Leukopenia, that's going to be a decrease in the white blood cells. Septicemia, you have bacteria flourishing in the blood. They're actually growing and multiplying in the blood. It can be any microbe growing and multiplying in the blood, but usually we'll talk about bacteria. Bacteremia doesn't mean that it's growing and multiplying necessarily, but there are bacteria in the blood. They shouldn't be there at all. But if there are any bacteria in the blood, that's going to be bacteremia. If they're flourishing, that's septicemia. You're becoming septic. Viremia, we've got viruses. I mean, I'm sure you can imagine fungemia for fungi. The subclinical infections. You don't know that you have this infection. Most illnesses have some kind of sign or some kind of symptom associated with them. So it's pretty uncommon to have total, complete, no symptoms at all. Usually people are just ignoring them. Yeah, headache or something. So people don't seek medical attention because it's not bad enough. Okay, so we had our infection, we were causing damage, and now we've multiplied, and now we're going to spread some of our offspring off to other guys. They're going to get out of our body through secretion, excretion, discharge, and sloughed tissue via all of these different mechanisms. Coughing, sneezing, insect bite, removal of the blood, like if you are using needles, and like we're talking about, you know, Hep C, you know, sharing needles as like heroin drug users. Did you know you can bleach your needles? That in one of the slides later on. I just thought I would bring it up because I thought that was wild that they suggested that in the slides. And they're like, if you bleach the needles, then you're safe from Hep C and HIV. And I'm like, or don't do heroin. Like, that's another option, I think, but anyways, you guys get it.
You're gonna do drugs, I'd rather you be healthy.
Right, at least bleach your needles, guys. Jeez. All right, we know you can slough your skin. You know you can poop it out. We know you can transmit it sexually, through blood, even via ticks, fleas, mosquitoes. That's a pretty obvious one. So those are more natural versions. So we have latency and sequelae. Latency, you got infected with something. Maybe you had symptoms and maybe you didn't. But if it is hiding out in your body and will come out later potentially, then it is latent. Okay? Oftentimes you do have recurrent disease associated with this, but here we're talking commonly about tuberculosis. So we're talking about latency associated with that. Malaria, I guess, kind of common. What is a very, very common one that becomes latent? Chickenpox. We mentioned that one before, yeah. Herpes. Herpes is forever. Herpes really is because we don't have any treatment because it hides out and puts its DNA in your DNA and it's impossible to get rid of it. Just like we talked about with HIV, there's no treatment and there's likely not to be treatment anytime within our lifetime. So herpes forever. And then we can say herpes viruses in general, including chickenpox, in case you didn't know that's a herpes virus. And so is mono. Okay, then we have sequelae. If you, let's say you get polio, let's say you're FDR and you got polio and now you're in a wheelchair and you might have paralysis, you might have severe difficulty using your muscles. You're usually neuromuscular degeneration, okay? If you had that and it's still continuing to be a problem after you cleared the infection, it's not going away or getting better, but continued forever, it did for FDR. So that means that's a sequelae. Long-term damage that is going to stay around even after you clear the infection. Can even get worse. Polio can get worse even after you've cleared it. All right, infections, how they progress. We have incubation period. That's just you first had maybe your first tuberculosis bacteria get into you. Are you going to start having symptoms right away? No, it's only one bacteria. Your body barely knows it's there probably. However, once it grows up and starts being recognized by your immune system, then we enter the prodromal period. That's our earliest symptoms. You start showing symptoms in the prodrome. Then we have the acute phase. You got all the worst of it going on. You're multiplying at high rate and everything like that. And then the convalescent stage where we start having a decline in symptoms and signs. That's how it would look. Some of them kind of hang around for a while. That's what that continuation period is about, but I don't need you to worry about that. I want you to know incubation period, no growth. So we're not responding to it. Once it's grown up and we can respond to it, prodromal stage, first symptoms. Acute phase, the worst of it. Convalescence, decline. All right. Some people act as reservoirs. That just means a place where people or animals can act as reservoirs, a place where this is maintained. And you can get sick from it at any time, but they're not necessarily always sick. And then source, wherever the disease came from, we would call that the source, basically. I don't know. It doesn't have to be from the reservoir, right? A carrier is somebody who has the pathogen, but doesn't necessarily know it, and they're spreading it around, like people with COVID that don't have symptoms, right? Or like Typhoid Mary. You guys don't know who Typhoid Mary is. Let me tell you. She was this lady that used to serve food, and especially to the troops and stuff like that. So she liked doing that. She would serve food, and people were getting sick. They noticed, and some seemed to be like she was there always when this was happening. So they tested her, and they found out that she had a certain kind of salmonella called typhoid, okay? Dysentery, bad. Anyways, they tell her that, they test her, they tell her to stop giving people food. You're not allowed to do this anymore. And she's like, okay, I understand, whatever. But she went back to doing it. So they basically like locked her up in like a healthcare facility for the rest of her life after that, because it was endangering people's lives. She knew she was getting people sick with this typhoid. That's Typhoid Mary, y'all. You learned it. She knew. She was Irish, I believe. We have living reservoirs, animals, of course, and actively ill humans that can transmit things. We have indirect versus direct. If I come sneeze on you, that's direct, obviously, directly getting you sick. If I, again, was like over here licking this the whole time I'm talking to you guys or coughing on it or sneezing on it more commonly, but you were to come up here and turn this off because I forget to turn it off, and then you get sick because you touched your face or something afterwards. That's indirect, right? I got this, contaminated, and then you touched the contamination and you got sick. You wouldn't have known it was there. This is a fomite. In that case, that's the word for that. I think we're gonna talk about that. Human carriers, we already know kind of they have a thing they don't know they have. Arthropods can work as reservoirs, so that's anything that drinks blood, like mosquitoes, ticks, that stuff. A vector, anything that's going to be transmitting the disease. We have biological vectors and mechanical vectors. If the organism is actually sick with the, if the animal is actually sick with the pathogen, okay, or it's reproducing in the organism, that's a biological vector, okay? Like what we see with malaria and the mosquitoes and everything like that. Mechanical vectors, your cockroaches and flies come and run across poop and then come and run across your food. They're literally just carrying it around. So that's mechanical. Zoonosis, we can already talk about this, yeah. This is going to be diseases that are spread to people from animals, usually due to close association. Here's some examples. We already know rabies, that's obvious. Leptospirosis, if you have a dog, that might be obvious to you. That's one of the things they can vaccinate for. Then we have some that I just don't really care that much about. Plague, obviously, that's going to be rodents in general, and the fleas that transmit it, that sort of stuff. You get it. And then non-living reservoirs where these things can just exist in the environment. Communicable diseases are any of the diseases that can be transmitted to people, between people. Ones that are easily very transmissible are called contagious. So contagious is just worse than communicable. It's a higher level. Then we have non-communicable. It can't be spread from person to person. An example of an infection that you can get that wouldn't be spread from person to person, if you're running through the hall and you scrape your knee and that gets infected, that's not going to get transmitted to another person. Right? Malaria. If you get malaria, people don't get it from other people. It's only from getting bitten by the mosquitoes. Horizontal transmission between people, basically anything where we're transmitting it, not from mother to child, basically. Vertical is going to be mother to child, genetically related, things like that. We already talked about fomites. Fomite is a type of a vehicle, a means to transmit these things. Kissing, all this other stuff, vector transmission. And we just said this. Oral fecal, if you guys don't know, that's a thing. That's what polio was. It was only in people. You drink water that's poop contaminated with polio. Water, and I just said about polio. I don't think you need to say that again. Air, things that can just hang out in the air for a while via droplet nuclei or aerosols. If you're sneezing, some of these things can hang out in the air for like hours. Like somebody cough in here with tuberculosis, the bacteria can like hang out for hours in the air, and someone just walks through and didn't even know someone even coughed there. It's crazy to think about. Robert Koch was the guy, I'm really trying. Robert Koch was the guy that found a way to tell what it was that was causing illness. Basically what he did, he took sample from somebody, separated out what was going on in that sample, took things and infected mice if they had the same symptoms and stuff like that. They'd extract it from the mice and either put it in new mice or test it again, and it's the same thing. And yay, we found the cause of it. He discovered the cause of anthrax that way. So that's called Koch's postulates. Oh, good. Okay. All right. So that is our question of the day would be, give an example of a syndrome and list associated syndrome. That's supposed to be a disease, I think. Give an example of a disease and then list associated signs and symptoms. So yeah, as long as you guys would be able to know the difference between signs and symptoms within, the diseases, then you start to think about it, the way you're meant to. And then we'll go to lab and do one of the most boring labs we've ever done.
Is it boring?
Yes. I'm not gonna lie to you.
You're honest.
Yeah.
usually, like, if you don't take your tuberculosis medication, they'll basically lock you in the hospital too.
That makes sense, yeah, because I feel like it's one of those things so irresponsible not to take the medication with that, because there's so many problems with drug-resistant tuberculosis. And it's one of those things that if it becomes completely drug-resistant, what do we do?
Yeah.
Like, just back in like the days of everybody having consumption and all that.
I work
so.
in a really tiny hospital and we had a patient who had like been infected with tuberculosis like that. And we still kept her in a negative pressure room and everything and had to, gear up.
Mhm.
We went in there. So I was just wondering, it's really possible that like